Thank you, everyone, for having me today. Can you guys hear me? Yeah. Small. We're going to talk today about transforming neurovascular programs with artificial intelligence. So we're going to talk a little bit about the evolving landscape of neuroendovascular therapy. I don't really have any relevant disclosures. I always start my talks by saying I only have interest. I don't have conflicts. I do have one very clear bias is I am actually very passionate about AI and incorporating it into our daily use. So just some background on who we are. So many of you have probably affiliations with Westchester Medical Center, but by way of introduction of the system, this is a 900-bed tertiary care hospital, 1,250-bed hospital, health system. It's the only level one trauma and comprehensive stroke center between New York City and Albany, and the primary referral center for almost 2.8 million people in the Hudson Valley, with a primary affiliation with, of course, New York Medical College. We have 9 spokes and community health, hospitals that basically refer to us that are part of the system. This, just to put things in perspective, again, 10 hospitals, 1,250 beds, 8 counties, 3 regions, 3 million people, 3,000 physicians, 12,000 workforce members. So today we're going to talk a little bit about how we were able to push the boundaries of stroke care. So why did we think of AI for Westchester Medical Center? So we had a problem. We had a set of problems. We needed to, we have a huge population with hemorrhagic stroke and ischemic stroke. However, these are in smaller community hospitals that will refer the patient to us, but we noticed that there was a huge delay in sending these patients over, largely because of the lack of detection. So this was, they were not, many of these strokes were, and hemorrhages were missed for hours until they were transferred over to us. We recognized very early there was a problem with our workflow and integrating the training, integrating and training the spokes with the hub. Many of these hospitals did not feel that they're part of the same system. And even when they did, they didn't know what to do with this relationship. We had an issue with remote monitoring. We did not have any monitoring of what happens in these spoke sites. So if a stroke was missed at an outside hospital, smaller outside hospital, we probably did not know about that. And likewise, if a patient had a very small hemorrhage that was missed initially, that patient could go through the entire stay with a small missed subacute subdural hematoma that could be very difficult to pick up, and the patient could be again, they could fall through the cracks. We had an issue with resource optimization. There was this huge strain on the health system, and also the data was not really accessible. Some sites had one software, one EMR, another site had another EMR. And we weren't going to be able to essentially solve all of these problems simultaneously. But as far as stroke and endovascular care is concerned and intracranial hemorrhage is concerned, we found when we were approached with this problem, when we joined in 2017, we figured maybe AI has a solution that could essentially tie everything in together and bring everything just to streamline the process. So what we did was we incorporated this imaging software called Rapid AI. And basically what Rapid AI does, for those who are not familiar with this, is it's a comprehensive system that allows every single CAT scan within the health network to essentially be, it's a plugin that is added to the CT head, and it's not intended to replace the physicians, but it basically picks up any tiny hyperdensities, any tiny bright spots, any tiny blocked blood vessels or cut up in a blood vessel in the brain, and it will basically just ping that and bring it to the attention of the radiologist, who would basically then say, yeah, I agree, or I disagree. This is just a loop in the blood vessel, or it's just a tiny speck of calcification. But at the same time, because everybody in the health network received this software, I was able to essentially look at and review imaging in all the different spokes that would refer patients to us. And if something was missed, yes, the radiologist would be able to see it. And now the radiologists who, in many cases, were Nighthawk radiologists, they are like based in New Zealand or Australia, reviewing imaging because there it's day and here it's night. So they'd basically be able to review all the images. And then now this radiologist is saying, oh, wait, Rapid is telling me, this AI software is telling me that there's a blockage in this blood vessel. So let me just pay a little bit more attention to this. Or maybe I need to escalate this. Let me refer this to a neuroradiologist as opposed to like a general body radiologist. This is now a neuroradiologist who's looking at this and saying, oh, maybe there is something there. So basically when a patient was, so this software, and again, it's an app that I have on my phone. As soon as a patient comes in with anything that is remotely abnormal, I get a notification. I'm on call. I pull up my phone. I look at it. I'm like, yep, it's something. It's nothing. If it's something, on that same app, I'm able to essentially communicate directly with the entire team, even if they're like 4 hours north. I can give my opinion and say, you know what, there is actually a blocked blood vessel, or I can let my fellow know, so we can essentially transfer this patient in. So I'll show you guys exactly what we did and how we incorporated this. So the patient basically, it comes to the emergency department at a spoke or a community hospital, and they have different modules. There's a module for stroke, ischemic stroke. There's a module for hemorrhagic stroke. There's a module for aneurysm detections, any irregularities in the blood vessel. And you can see that the number of times that a scan was successfully done, and by scan I mean like the Rapid AI software was able to be executed successfully, has increased significantly. We had, like, in 2023, we had almost 9,081 scans that were completed successfully, and the processing time is minimal. So part of the concern many of us had was, how long is this going to take? It's going to delay the process. It delayed the process by approximately 63 seconds. So definitely worth the wait until, because many of these patients, like I said, were not really detected. We were missing them. With regard to like large vessel occlusion stroke, so there's a blockage in a major blood vessel in the brain. We were able to increase the number of detected large vessel occlusion that were suspected. Again, they're never going to say, yes, we detected it. They say, we suspected it, and we escalated this to the radiologist. The number, this is the same population, by the way. Like, this is the same region. Nothing really changed from 2021 to 2023, other than including that software. And the number increased from 240 to 797 scans, successful detection of large vessel occlusion strokes. And of those, how many were eligible for an intervention? So you can say, sure, it picked up scans. Did it really change your management? Almost 72% more patients underwent life-saving interventions who otherwise would have not necessarily received this. It could have been missed, because now those are patients who we pick it up and we transfer the patient over, and we're able to execute. We were able to act on it. So these are actually our numbers. You can see pre-Rapid AI and post-Rapid AI. We had approximately 48 additional procedures annually. So a 33% increase in mechanical thrombectomy. And the numbers I showed you earlier were the number of cases that were essentially transferred over. So we had like almost a 70% increase in the transfer rate. So with regards to, I just wanted to focus a little bit on like Rapid AI and its accuracy. So one of the questions is, well, if there's a tiny loop in the blood vessel, the AI module is going to essentially initially treat this as it's a blocked blood vessel. It's not really seeing that this vessel looped and made a turn. But the thing with AI is, over time, as you, it basically reads your decision. If ultimately you said, I disagree with AI, this is actually a turn in the blood vessel, this feeds back into the system. And then the next time, it's not going to make that mistake. Or it may make a mistake with a more distal branch blood vessel. But over time, when we've had like almost 9,000 scans, it's learned so much from this. So at this point, we're talking about like Rapid AI 4.0. When we started at 1.0, there were so many mistakes that the AI software was making. Now, it's actually very, very good. Now, when it actually pings me, my heart rate, and it takes a lot to get my heart rate to go up, but now my heart rate goes up because I'm like, oh God, it found something. Now it's going to tell me that I have to come in at 3 a.m. in the morning to do a thrombectomy. But again, we chose rapid for a very particular reason. We felt that we were offered Viz AI, we were offered AI Doc, which is what Westchester has and actually currently uses for the entire body. So now at Westchester, radiology, and I think Dr. Gulka may talk a little bit about this later on, AI is part of every single radiology protocol, whether there's a tiny nodule in the lung on a chest x-ray that could be missed, or a tiny hyperdensity in a kidney, or a tiny cyst somewhere. It's not going to read it. It's going to ping it and bring it up to the top of their line and say, hey, maybe there's something there. I don't know. AI, up until this point, is very humble. I don't know what it's going to look like and how it's going to be talking to us in 5, 10 years from now. But I will tell you guys, and it started as a joke, but I started teaching my kids to do this as well. When I ask ChatGPT something, I say, could you please do me? Answer this. I have to be nice because I don't know what it's going to do. Maybe it's going to remember, oh, this guy was mean to us. And on that note, I noticed my kids, when they talk to Alexa, they're mean. I'm like, why are you so mean to her? They're like, oh, it's not real. I'm like, no, you still have to be polite. Use you have to say please. So now I'm teaching my kids to be nice to AI as well. So you can see over here, the sensitivity and specificity is actually very, very high. With regards to stroke, large vessel density, the non-contrast CT head telling me whether there is an established stroke in the brain or not, whether there's a small intracranial hemorrhage that's detected or not, whether there's a subdural hematoma, bleed outside the brain or not. In some cases, these could be very, very hard. Also an aneurysm detection. So aneurysms are very, very difficult to pick up. And these are very dangerous. So you can think of, from a medical legal perspective as well, if somebody comes in with a ruptured aneurysm and they say, oh, I actually had a scan of my blood vessels in the brain 3 years ago. Nobody told me I had an aneurysm. Make no mistake, the lawyers will go back and they will see that somebody missed an aneurysm in the brain. So this has made so many people's lives so much easier. And honestly, safer for the patients. Now, the advantage of this is it's able to deliver care anywhere, anytime with rapid aspect. So I was at a conference 2 weeks ago, and a friend of mine called, and they were able to reach me because my partner was in surgery, and they said, oh, wow, I spoke too much. My partner was in surgery, so they called me, and they're like, hey, can you take a look at this? Within a second, I pulled up my phone, I was able to pull up the images, and I immediately told them, like, nope, this is not a stroke. You don't need to worry about this. I've reviewed the images for you. So basically, AI was able to improve reader diagnosis, elevated the readers to an expert level. So I'm not a radiologist, but it was able to help me figure out, yes, this is I'm able to read at the accuracy at the level of a radiologist, potentially. It has a superior accuracy with a 45% reduction in inter-reader variability. So 2 radiologists or 2 interventionalists could read the same image and we could disagree. But when we both looked at this and we were fed this information, our numbers became much more closer. We could still disagree, but instead of I say 3 and they say 6, now we're both saying 4 and 5. There was this direct to PACS, so it goes directly into our radiology imaging software, and that made our life so much easier. In the interest of time, I'm just going to try to move on. So going beyond large vessel occlusion stroke, so this is a case where it was able to compare one side. So with neuroimaging, we compare one side to the other, half of the brain. You're able to tell, is there a preponderance of more blood vessels on one side than the other? And it's able to tell you whether this exists. It's also able to tell. So sometimes it's very easy to tell if there's a larger vessel that's blocked. But when you're talking about a very distal branch in the brain, it becomes very hard when you have 50 other branches coming very close to it. This is able to pick up almost 93% of medium vessel occlusions as well. So here, I think just in the interest of time, I want to be respectful of everyone's time. One other thing that we're incorporating here is angioflow. So I'm able to detect, to conduct a perfusion study of the brain on the angiosuite table. And this provides clear, easy to interpret perfusion maps with a single injection, like with my hand, and I'm able to pick this up. And that way, I'm not putting them in a separate machine. I'm getting this information directly on my table. Within seconds, I'm able to get this information. So we're actually using this information to conduct something called the cognitive trial. So, I'm done here. I'll end over here. But I was approached by industry to conduct the trial. The trial was, I was like, well, what's the study? They were like, well, like, we did a trial. We want you to do part 2. I'm like, what is part 2? They're like real world. They did the first trial. They got FDA approved. They want me to do another trial, and they're like, like real world application. I'm like, I don't do that stuff. Like, that's like, you already have proof that it works. I don't need to do a study. Look at me. I can do a procedure with standing on 1 feet with like my fellow like singing to me. It's just a ridiculous study. I'm not. It's a waste of my time. It's a waste of your money. We're not going to do this. They're like, well, what do you want to do? I was like, well, really interesting to look at if a patient has a blocked blood vessel, and I open up the blood vessel, will there be an impact on cognition? So we know that their strength is going to be better, but is their cognition going to be better? And I think that's a very important question. Because I remember I had this one patient. We did a perfect thrombectomy on them. We opened up a blood vessel, and the husband came back, and he said, Doc, yeah, I know you're very excited and very happy about my wife, but this is not the same person. She doesn't shower. She doesn't cook. She doesn't clean. She doesn't change her clothes. She's like, this is not the same person I married. So yes, you're happy that she's able to move her arms, she's able to speak, but that is not the same person. Cognitively, she looks like she's got dementia. However, when I ask her, remember 3 things, she remembers, she'll pass a test. But there's a lot that we're missing. So we decided that we're going to come together, and we're using this AI module to essentially pick up, are there any tiny branches in the brain that are missed that I could miss with the naked eye, and that rapid AI software can essentially pick up. So then we can essentially say, yep, these are patients who need further treatment, and I need to chase those blocked blood vessels. All right. And with that, I'm going to end here. I'm not going to go over the rapid aneurysm. These were some cool images, but all right, of course. Thanks so much.
We have time for maybe one very brief question. Thank you. Okay, our next.
May I ask a question?
Oh, yes.
Hi, sorry, I had a quick question. So we have been using algorithms to expedite counting beta cells with different patterns. And I see the same thing is applied in clinic to see different things. Radiologists, for example, looking at aneurysm and so forth. And I heard that you take into account divergent opinion of physicians that feeds back to the machine to train it better, right? Is that also a way to introduce maybe things that are not correct and should not be taken into account? I guess at the end of the day, I'm just fast forwarding 5-10 years from now, is it going to be the responsibility of a machine or a physician to make this decision?
Yeah, so I mean, I didn't get a chance to go over the numbers, but the discordance rate between the disagreement between 2 physicians reading imaging today on the same scan, believe it or not, is around between 30 and 40%. 2 physicians, 2 experts could disagree on whether the number, like whether the one area in the brain is affected or not. And what this system is able to tell us is, you can even think of it as like a third reviewer. However, this time it's learning from the 2, and when the 2 basically sat down and discussed this, they said, oh, we actually think if, say, just from a brain perspective, one person gave a score of the areas in the brain, like 4 areas in the brain were affected, and the other person says, no, actually 6 areas in the brain were affected. Ultimately, they discuss it and they say, well, now that we discussed it, we think, yeah, we agree, 4 areas. In this particular case, 4 areas were affected. One person wins. The machine is able to basically, this feeds back into the machine. And so the next time they say, okay, so it basically minimized the inter-rater variability significantly. Now it says when, guess there may be some disagreement, but the vast majority of people, when they had the exact same image, they felt that it was closer to 4 than it is to 6. So now you have a third person who is essentially with an expert opinion, a third entity with an expert opinion from like not 2, but basically 50 or 100 other radiologists. And it's basically coming up with like a mean value, but not based on just like an absolute mean. It's based on, yep, they sat down and they were like, there was an adjudication process, and ultimately the majority rule was essentially with 1. It wasn't just like an average. It took like average between 2 and 6. It basically said, no, the vast majority of people felt this way.
Thank you very much. Al-Mufti, very nice. Thank you very much, Dr. Al-Mufti.